Alison, thank you so much for sharing your story. I can see how much it takes out of you to do that, and we're just grateful that we can learn a lot from what you've said, and that's what I'd like to move on to now. So I've got a few things that I'd like you to sort of address for us. So the first thing is, you were in a good hospital. You described it as a good hospital, or thought of as a good hospital, and the people working there wanted to do a good job. Yep. But you didn't always get the care that you thought you needed. Why do you think that was?
I think firstly, I will never truly know. Only the people who are there probably know absolutely everything, but I have my own opinions of what I saw and experienced that inform that. I think you have to question what was the competency. That's not a criticism of the people, that was what was the experience, speciality of the people that were looking after me. Did they have that necessary experience in a trauma setting to deal with my injuries or recognise a deterioration? Did they have the training necessary on early warning scores and obviously news too? Was there cultural issues where people felt they couldn't escalate and raise issues? I know there was nurses, junior doctors calling for help, and there wasn't those things acted on. Was that because they weren't listened to? Was it because they weren't communicated? Again, it's something I can only suspect or not. The other question is, was it capacity? Was it that people were just so overstretched they couldn't actually act? And therefore, is it a combination of all of these things that then mean it just becomes untenable whichever role you're being, because people are too stretched, they are unable to deliver the competency of what they're trained? Is it that the communication breaks down so the right people are not called at the right time, so you don't have the competency to the care? Is it all of those things that then mean the outcome just falls apart? And I then fell through every single part of that in a very, very unfortunate way. I can look at very individual points where you look at it and you think, this is blatantly obvious. This girl's sick and it's going wrong. Why on earth was it not picked up? I don't want to proportion blame. I don't think publicly that helps any individuals. It makes it very difficult, but what they do need to do is question why those things went wrong and actually make sure it doesn't happen again, whether that is a case of competency, whether it is a case of culture, communication, and capacity. And that's not any one individual's responsibility. I know some of the blame was laid at the door of the junior doctors and the nurses for not communicating. They did, and I don't for 1 second blame those junior doctors. There's responsibility at every level for things going wrong, for how a ward operates.
Okay, so you talked there about, what you're talking about in particular is those days between you being admitted to the hospital, before you had to go to surgery, or before you did go to surgery. It is true that sometimes serious illnesses, serious injuries are managed by waiting and watching and monitoring patients, and sometimes aggressive treatments are not needed, and some of those illnesses and injuries can resolve spontaneously. Can you identify when it was absolutely clear that policy wasn't working?
I completely understand that, and I had complete trust in medical care. And the approach is obviously you admit someone because you're concerned, and they're going to do one of two things. They're going to get better, and you're going to discharge them, or they're going to deteriorate. Well, if they start to deteriorate, someone has to start to ask the question, why? And there was two aspects of that. One is my deterioration wasn't picked up. It was attributed to something else, and the wrong action was taken. And secondly, no action was taken at some points. So, for example, on the Wednesday evening and the Wednesday night, when I had started to vomit, I was catheterised, I was still in pain. The nurse on the night shift felt another scan was needed, had escalated that, and that was overruled for whatever reason. I can't assume. I look at my notes and I see that page on my notes where my heart rate is high, I've got no bowel sounds, my white blood cell count is dropping, my urine output is low. Why has that not been picked up on? What reason was it that was dismissed? Or why did they feel that score or deterioration was appropriate? Those questions didn't seem to be asked. What is causing this physiological change and deterioration in the patient? And then even through that whole day, my parents were asking about why I was in so much pain. They were asking why another scan wasn't being done. And my friend that evening was concerned, but there was no way to communicate that. And I then still deteriorated through that next night even further. So in what we would see as sort of the news too, it would be ringing alarm bells. Someone should have been taking action, not only that morning to ask why, but continually at all of these points there should have been action taken. And there's two aspects when we look at deterioration, I feel. One is the rapid action to the patient that is seriously unwell and deteriorated, but also identifying the patients when they start to deteriorate and stop them getting to that point in the first place, when they are so critically sick. And it was missed in terms of escalation, monitoring, communication, and action, because you can monitor as much as you like, but if the action isn't taken, it's pointless.
Okay. That's really helpful, thank you. So, in terms of thinking of if there's two parts to the rapid response component, or potentially rapid response component, there's the ward team, which is the nurses and the junior doctors, and then there are the senior team that might be called in or are called in to help at certain key points. What would your message be to the regular ward team, the ward nurses and the junior doctors that are there most of the time?
I would say they don't, or I would like them to appreciate how important their role is in doing some of the very basic things. Doing things, measuring the heart rate accurately, doing blood pressure accurately, respiratory rates accurately, because those things are going to have a massive impact in identifying patients' condition and alerting as quickly as possible to any deterioration. And it may not seem like a glamorous thing, but it's so important, and it can have a massive difference to someone's life. If they are able to act on those, record it, and then escalate quickly, even if they don't know why these things are changing, if they are able to say, this has changed, why is it changing? I don't know, I need to get help. If they do it through appropriate routes on their ward, but if that help and support to get the competent action isn't available, they should be able to bypass the ward and directly contact rapid response to get the help. Because the outcome is about giving patients the best chance of not being harmed. And if you're able to do that by monitoring, picking up deterioration, doing an accurate news score, and escalating to the right team, the outcome's going to be the best for everyone.
Absolutely. Okay. So in terms of escalation, Do you think that patients themselves or their families could have any role or should have any role in that in some cases?
Yeah, absolutely, absolutely. The way I see it is if I'd been lying in the street in the condition I was, I could have called 999 and probably had action taken, and anyone could have called 99. But I was lying in a hospital bed and none of my friends or family could call for help. They weren't empowered to do so, but they had the information, they asked the questions. I think if someone had said to them, if you're concerned on X, Y or Z parameter, my parents are intelligent people, my friends are intelligent people, they know how to use these things, and I think people would do so responsibly by not including the opinions and the observations of family members. It's excluding part of the jigsaw. You're only assessing half of the information and trying to make a decision and a diagnosis based on some of the information. And the aspects where I know that that is appropriate is that when I came out of ICU, my parents had built up a relationship with the doctors, nurses from ICU. And they would, although they didn't have a route to contact them directly, they would bump into them in the corridor, in the cafeteria, in the lifts, and they would always ask how I was doing. And it would take one word or one comment for them to pick up something isn't right, and they would be there to assess me, and my treatment would change, and there would be a next step in improvement. And you just think, if you were able to empower that communication from the start, you could have a massive difference in terms of outcomes for all. It's not about the ward staff and the doctors being wrong and the family members being right. It's about actually creating the safest culture available and the best supportive culture so that we can have the best outcomes.
Yeah.
When things go wrong, it doesn't just affect the patients and the family, it affects the doctors and the nurses too. And they shouldn't have to be stretched and put under that pressure as well. I have friends who are medics, who are surgeons, and I see the stress that they go under when they go home at night and can't sleep because they're worrying about a patient and whether they'll be monitored correctly and how they'll be the next morning. It's for everyone.
Alison, you talked a little bit about being monitored, and you've had a couple of experiences of being monitored on the ward and indeed in intensive care where you're very heavily monitored. And some of the monitoring in intensive care, although it might be helpful, is also tethering you to the bed, so has its downsides too. But if you think about the ward, which is the experience for most hospital patients, do you have any thoughts about how technology, either now or in the future, could be used to help people in your situation?
Yes, I think the first thing is that from an ICU perspective, I can't really remember the monitors. I know they were all behind me, and I wasn't particularly lucid at the time. So, but on the ward, definitely. But I also have a very strong sense that that can't replace the medical care and the interface between the clinician. I think it's a combination of all of those things. So technology is only as good as the data inputted into it. Yeah. And it is only as good as the interpretation and the actions that then arise as a result of looking at it. So one is the data put into the information has to be accurate and done so consistently. Secondly, it has to be looked at by someone who understands the data, questions why and takes the appropriate action. And I also think that that has put into sort of the context of news too, but it has to be in combination with gut instinct and clinical experience, because sometimes I don't think the monitoring technology can replace the knowledge that humans have of the condition of another human. I think there's an element where technology can have additional role to play. I look at my family members and people, whether they're in hospital, out of hospital, informed people, they couldn't see that monitoring. They didn't know what those monitoring was going on. They didn't know what my heart rate and blood pressure were doing. They didn't know even to look at it. They had no way to input into my monitoring, nor did I. I think that's an important aspect of it. Have family members noticed a change in their patient? Have they noticed a change in their cognition, in their pain? Are they concerned, yes or no? Is the patient better or worse than yesterday? Even the patient themselves, I don't think I wouldn't have been able to, I was in excruciating pain, and people say you can't remember pain. I remember that pain when I was pressing or screaming at my father to press the PCA and the morphine pump. It was a desperate pain. It was almost I can't take this anymore. But if I'd been able to record my pain levels, I was also still trying to tell my fans, it's fine, don't worry. But if I was able to record somewhere, no, I'm feeling really, really in pain. I need some help. I'm really in pain. Or even afterwards, when I became septic again, would I be able to put, I feel worse or better than before? Because I was pretty sick, so you don't feel good, you feel awful. But I was able to say, do I feel better than or worse than earlier?
So it would have been good if you could have inputted yourself into the...
Absolutely, but family and friends as well, and not just family, but any visitors, so that they were able to, because my friends know what I'm like as a person.
Yeah.
They know what I'd normally be like. They know if I'd been confused. They know that I wouldn't be making a fuss about pain. So if I'm saying I'm in pain, they're thinking, oh yeah, she's hurting.
Yeah.
It's real. There's something wrong here. But it's about empowering those people to be able to input it in a generation where I have respectful, knowledgeable, intelligent friends who are not going to cause a fuss or be impolite or necessarily challenge unless they really are empowered to do so.
Yeah, thank you for that, Alison. So, just to finish off, could I ask you to say what are the 2 or 3 things that the public could do differently and clinicians could do differently in these kinds of situations?
I would say for the public, first of all, I would say have the confidence. If you feel there's something wrong with your family member, raise your concerns, explain why.
That's not always easy though, is it?
It's not, no, it's not, absolutely, it's not always easy because you feel it's a busy ward, busy hospital, you don't want to cause a problem. But if you notice something, you have a right to. That's not about causing problem, it's about doing it in the appropriate way. But I think there's also a part of an education perspective in hospitals and for clinicians as well, is actually what should families and patients escalate and communicate to people. And if we're able to provide that information to people and patients on the ward, then people would be very much more informed about how to. That could be about a call for concern. How are you able to directly contact rapid response? Which I feel that every member of staff and patient and family member should have the availability to do so, but having the guidance about when and how to do so people are empowered. I would also say from a clinician's perspective, the patient's voice and the family's voice, if they have concerns, is absolute paramount. People don't want to cause problem in hospital. They're frightened, they don't want to be there, they don't enjoy being there, they want to be better and they want to get home. If they're saying something's wrong, it's not because they're causing problems, it's because there probably is something wrong. So if you ask the question why, give an answer and provide the reassurance and be sure. But also listen to all the nurses and the junior doctors on the ward, because the nurses are there 24/7. They're the ones talking to the patient and they get to know what's going on. That's important.
Alison, you've had some involvement with the International Society for Rapid Response Systems. You spoke at the conference that they ran last year and also at the Patient Safety Congress. What do you think the value of that organisation and those meetings might be in the future?
Gosh, in the future, I think they already have enormous value. The rapid response teams as a whole, they should be without doubt in every single hospital, without doubt. Available at a very minimum for ward staff to be able to bypass the hierarchy on the ward if they've got a concern about a patient. And I believe that, I firmly believe that by doing so, if you have a patient that is deteriorating, where their News 2 score is showing signs that they need help, then there should be rapid alert so you get the right people at that bedside to do the right treatment at the right time. And with the rapid response team and the society, that is about demonstrating the value of that to patients, to healthcare and physicians as well. Because I have no doubt in my mind that by having rapid response teams and the important infrastructure in hospitals, that will reduce ICU admissions, it will reduce length of stay in intensive care, that will reduce length of hospital stay of these patients. And the long-term damage that does to patients, we know that just one less day in ICU for me would have been important. If I hadn't ended up in ICU, wow, what difference my life in the last 6 years, my life would have been. And for some people that means they don't lose their loved ones. I'm lucky. I get to sit here and I get to shout and tell my mum and dad I love them. Some people don't. And I think that's the difference between having a rapid response team and the right people at the bedside or not.
Okay. Is there anything else that you think you'd like to say to the people who might be watching this film?
I would like to say that actually having worked with the International Society of Rapid Response Systems, with the HSJ Patient Safety Congress and people at UCL, is that it's overwhelming how many people are committed to try and make a difference in terms of preventing deterioration, identifying deterioration rapidly, implementing News 2 so there's a consistent monitoring, preventing patients ending up in intensive care, making sure rapid response teams work, because it harms the clinicians to see those patients. It's not good for anyone when things go wrong for patients, and when you see how many people are working behind the scenes to change that and change the harm that is done to people like me, people that have lost their loved ones, it's incredible, it's inspirational, it gives an enormous amount of reassurance to me that there are people trying to keep you safe. The other thing to think about is that I am incredibly grateful and thankful to the people that saved me. The surgeons, the ICU consultants, the nurses that seriously helped me every single day, whether it was learning to walk, bathing me, the bedpans, or just smiling at me and asking me how I was. There isn't a day that I don't think about those people or the ICU consultants. The person that restarted my heart, I don't know who that person is. I won't ever stop thinking about them, but the biggest thank yous are still the ones that you'll never receive, because they'll be the patients that didn't have to go through all of that. They're the ones that you stopped them deteriorating, they walked out before they were harmed.